Hi again, Dr. Lee Coleman, welcome back. This time I want to talk a little bit more about how to help patients and talk a little bit about the way that I've done it in my career, how it's different from most all psychiatrists, not in every way, but in I would say the commitment that I made to things which very few psychiatrists are willing to do. Most of them would probably say because they don't agree. But it is scary to do it the way that I did it. And let me give you a little background. When I finished my psychiatric training, and then I had 2 years to serve in the military, I had not formed the views that I have about forcing treatment on people being not a good way to help them, because as a trainee, you certainly were involved in forced treatment. No question about it. We worked in inpatient settings, and in certain situations, we had the ability to make sure someone was put in a hospital, whether they wanted to or not. And while they were in there, they were given medications, and they sometimes didn't want to take them. There were even a few cases of electric shock treatment. I never felt good about that, but there were a few cases where it was outside my control. But it was a little later that I ultimately decided my opinions evolved based on my experiences. And that primarily happened when I was the head of the emergency psychiatric services of a local county mental health system in the San Francisco Bay Area. So that I had a team of about a dozen people working under me. I was the only psychiatrist on the crisis team, as we called it. And that was the emergency division of county mental health. Had the psychologists, social workers, nurses who had extra training in psychiatry, and we would all collaborate and work. This was in the early 1970s. We would work with patients we had an inpatient unit, meaning beds for people could stay in for round-the-clock care, but we were set up only to keep them for 2 or 3 days. If the opinion was that they needed longer-term care for maybe weeks, possibly even longer, there was an inpatient psychiatric unit just on the other side of the door from our ward to a unit which would take patients who needed care longer. Those patients were, some of them there voluntarily. I should put quotes around that, because in psychiatry, it's easy for you to be voluntary as long as you're willing to stay. But the minute you decide you don't want to stay, you will then be made involuntary. And I've advised many patients, if you're in a situation where you don't think you're ready to leave, that you want to go in, they're insisting on it, don't sign in voluntarily. Don't let yourself, because they can keep you longer if you agree in the beginning, and then later they make you involuntary. But that's a little bit of a digression from what I'm talking about now, which is the evolution of my opinions, my way of working with patients. So in the crisis team, we had patients who were there against their will. Sometimes they came to the crisis unit, to the emergency room of the hospital, and then once it was seen by the admitting doctors that this was a psychiatric problem, there would be a referral to somebody on the staff who would come and talk to them. And if then the opinion was they needed to be hospitalized, that would be done, whether they agreed or not. And I was part of that. I would maybe get there the next day, and there would be a new patient, and they would be on an involuntary hold. And it was at that point, as I'm now in the midst of psychiatry, I'm no longer a resident, I'm no longer a major in the Air Force, at the United States Air Force Academy, and working in a sort of a separate milieu. I'm seeing all the nitty-gritty of what psychiatry sees: suicide risk, aggressive behavior, psychotic breakdowns, impulsive, manic-y behaviors, alcohol, drugs, all those things. I gradually am forming opinions about how we're helping people or not helping people. I see the amount of drugs that are being used, and I don't actively try to stop it, because I'm involved in a milieu with many, many people who have their opinions And I gradually formed opinions which were maybe bubbling around in my thinking, but being head of the crisis team, I'm evolving in a more concentrated way than I would have been, say, in a private practice setting, so forth, that I don't really think that it's a good way to help people by keeping them there even though they don't want to be there. That I see that when there are examples of somebody getting somewhat aggressive, it seems like every time it happens, I mean aggressive on the ward, let's say, with another patient getting into maybe a fist fight or with the staff being hostile, it always seems to have to do with the fact that they don't want to be there. Now, I can't prove that because there's no scientific test for why somebody's doing what they're doing. But nonetheless, it's an opinion that's being formed from my experiences, what I'm seeing. We're talking, the staff, we're talking with each other every day about the various people. We run down all the people and everybody gives their opinions about what they've seen and so forth. I'm gradually forming the opinions, sometimes staff is running after a patient while they've somehow gotten out through a door that wasn't locked and they're seen to be walking across the parking lot. And a staff member is running after them. And they get taken back, and they are very hostile. And I'm thinking, I don't really think that's such a good idea. I wonder if we really help more people than we hurt by doing that. And I'm also seeing people who've been on medications for a long time because they're not kids anymore. They're in their 30s, 40s, 50s, and maybe they've been on a lot of medication for a long time. And I see the side effects of the medication, the things that it's doing that you don't want it to do, but it does anyway. For example, the effect on people's muscles, the restlessness, a thing called akathisia, where you can't sit still, the cramping that can occur, the movements around the mouth and the tongue called tardive dyskinesia. These, even then, were known to be unfortunate effects of the medication. You wouldn't want that to be there, but it was accepted as part of what you had when you gave those medications. So over the next 2 years, maybe, where I was actively working on that unit, I formed the opinion that forcing help on people was not turning out to be as much help as we hoped it would be. And I began to think more about, well, what's going to happen when the person finally does leave? They've been accused of any crime. Sooner or later, they'll be in a situation where they'll be free to avoid us. And so then I began to think, I have to throw into the equation, how much will the person not get help because they've learned to be afraid of us? Because we are in charge. That is, we make the decisions whether something will be forced on them. Ultimately, I form the opinions that by now you know that I have, that we will lose far more of the help that we might offer when we force them. And also that I became convinced that patients will be better at deciding whether they should accept something than we were. Now, that really gets a lot of psychiatrists upset to think that people who have such a distressed life would be better at knowing what to accept than the doctors know with all the training and all the sincere desire they have to help. I've said this before, but I just want to repeat it again. The reason I believe that, and again, I can't prove that I'm right, but then my critics can't prove that they're right either. None of us can prove it. But I'm convinced that I'm right because I think that we will drive away the people at the very time they are most susceptible to our help. In the early stages of these major problems, if they have had experiences with us that they didn't like, and the problem went away for a while, but now it's coming back, they will not feel free to come back and get help, genuine help at the time. If they came back sooner, we wouldn't be so tempted, or the people who do this wouldn't be so tempted to pile up the medications. There's a lot of harm that is done to people through the medications. I've already told you that in my view the medications are not treating any disease because there's no known disease there to treat. They do cause abnormalities in the brain, which then become an extra problem for the patient. So psychiatry is perpetrating harm. Let me finish up by just saying that due to my dealing with these discussions in other settings over the past years, I know that one of the things that other mental health professionals will level at me, and I don't accuse them of being of lack of sincerity or anything else, is that, well, Dr. Coleman, you're not dealing with such serious problems. You left the arena of the mental hospital. You left the arena of the people who are so ill they can't give consent, so we need to help them and overcome this lack of consent. Make them take it anyway. Well, they're right in the sense that, yes, I didn't practice in a hospital setting for most of my career, only in the early part, because I made a decision. I had to put my money where my mouth was with regard to forced treatment and not participate in it. I was able to help people who had been through forced treatment and came to see me because they believed what they had heard and what I told them. I do not participate in involuntary treatment for any reason. You never have to be afraid that if you're seeing me, I'm going to ever make you go into a hospital, which is so easy for a psychiatrist to do. One phone call and somebody will show up with the authority, whether it's police or some sort of county employee, will take them. So it's true that I have not practiced for a long time in that area, but that is not my doing. That's society's maintenance of a system which continues to force treatment on people and not let them have the say, and now has become so medicalized that what will be done to them is inevitably heavy drugging in those kind of situations. There are people who have tried for a long time to try to have those alternative kind of institutions. And what the psychiatry's response has been to fight it tooth and nail, to just try to discredit it. So we as a society have not been willing, we have not had the courage to recognize that we may be part of the problem when we support this kind of involuntary treatment and heavily drug-oriented treatment. When shock treatment is portrayed as it was on 60 Minutes, I recall Dr. Lisenby said, if you've tried the drugs, don't be afraid to ask your doctor about shock treatment. Just like one of those TV commercials. Ask your doctor about. I would hope that society will begin to recognize that we've tried it for a long, long time by overcoming people's will, by forcing ourselves on them. And all the data indicate that more people are being put in mental hospitals than ever before. They may not stay as long as they used to in the same buildings, but due to more and more diagnostic manuals, more and more drugs that are claimed to be doing this and that and the other, psychiatry is creating labels which make more and more people. Children is a huge category. And so I don't think it's necessary to defend the fact when somebody says, I'm going to do it a different way. I wish more people would do it another way, and we might begin to see some good improvement. Thank you very much for coming.